Good evening, everyone, and welcome to the monthly meeting at RR Hospital. This meeting is little delayed because of the uh, Nachi conference. Delhi is being looked upon by every other society for being so united. They are very surprised that whenever there is one activity of any uh, forum of Delhi, the other ones they cooperate and they really appreciate. And the other thing which I'm hearing, which I must tell every Delhiite is that they're really appreciating the programs being done by AOGD. And they say if it is by Delhi, it's going to be a good program. So I thought I'll let all the members know that your work is being, acknowledged nationally. And we had a good month in August, begin with Delhi getting the prize for the activities of breastfeeding. From the North Zone, the first prize due to the effort of all of you who did the activities. And this time we will have two meetings in this month because this is the last month meeting, and then the last Friday we'll have a meeting of DDU. And now since Monica has joined, so I will hand over to Monica for giving the secretary's report.
Thank you, ma'am. I'll just share my screen. Is the screen visible?
Yes.
Yes, ma'am. Make it full screen.
Okay. Okay. So, good evening, everybody. And I'm here to present the Secretary's report for the month of August for the events and activities what were held in month of August under AOGD. So I begin with the last AOGD monthly clinical meeting, which was held in Sitaram Bhartiya Hospital on 30th of July. It was a well-attended and appreciated meeting with very interesting topics discussed. Then, as Dr. Achla has just apprised all of you, we had wonderful celebration of World Breastfeeding Week, and AOGD participated wholeheartedly in that. And we had lots of programs like, this was the radio program given by Dr. Achla. Then there were newspaper coverage of our activities. Then we had, every day we had some or the other activity from 1st to 7th of August. We had peripheral, rural health forums, public forums. Then we had nursing forums, nursing college students were participated. And even, non-medical college students also participated. We had public forums for that. Then these were hospital activities where we counseled and, educated the new postnatal mothers in inpatient wards and distributed important things which are required for breastfeeding. Then we had lots of activities like nukkad nataks, quizzes, forums in OPDs. So, and we went all heart out and participated in the national activity as well, which I'll be coming later. Then we had the main AOGD event on antenatal vaccination and labor care, which was very well attended and appreciated, especially with our residents and practitioners. Then our oncology subcommittee conducted 3 programs, one of which was masterclass on gestational trophoblastic diseases on 31st July, masterclass on endoscopic approach on to surgical management of endometrial carcinoma with endoscopic committee on 19th August, and hereditary ovarian cancer management, which was there on 21st August. We then had programs under our AOGD multidisciplinary subcommittee, which had a webinar on contraception with the DGF Southwest on 28th July. Then optimizing normal delivery and cesarean webinar in association with DGF Southwest on 4th of August. There was a panel discussion on pregnancy with thyroid diseases in association with DGF Southwest on 20th August. Then our rural health subcommittee did a wonderful lactation management workshop with the Indian Academy of Pediatrics East Delhi branch on 13th of August. Our AOGD Safe Motherhood Committee did a CME in Lady Harding Medical College in association with NARCHI on reigning in cesarean pandemic on 4th of August. AOGD Fetal Medicine and Genetics Subcommittee did a CME on improving fetal outcomes in maternal medical conditions on 13th of August. Then our adolescent subcommittee did a program on challenges during COVID pandemic in young population on 14th of August. Endoscopic subcommittee, as I said, in association with oncology subcommittee, did this program on 19th August on approach to surgical management of endometrial carcinoma. QI committee did a workshop on 5th and 6th August. Reproductive endocrinology subcommittee did a program on recurrent pregnancy loss and luteal phase support in ART cycles with DGF Outer Delhi. This was on 31st August. Then there were various programs held under aegis of AOGD as well. First being by FOGSD, which organized a webinar on recurrent pregnancy loss in collaboration in association with the Independence Day celebrations under aegis of AOGD. Then Manipal Hospital did a program with the DGF Dwarka on thalassemia and other autosomal recessive disorders on 19th August. And another program in Lady Harding Medical College was organized under the aegis of AOGD regarding infertility capsule and IUI workshop on 26th of August. Then a special mention for our outreach team member, Dr. Kusum Chopra, who has done some wonderful job in periphery, especially in rural areas, and this in association with the Rotary Club India. She's been doing some, recently she's launched a menstrual hygiene management program in the rural population, and she's distributed some important kits and given a lecture on the public forums for menstrual hygiene management in villages of Mathura. Regarding the academic aspect, AOGD launched a wonderful issue of AOGD Bulletin, which was targeted mainly on the basics in minimal SS surgery, and it has been well accepted and well received amongst the residents and practitioners. Regarding the achievements at national level, we won the first prize from North Zone in the Foxy World Breastfeeding Week celebrations for all the activities we did, which I described in the beginning of the report. The members of AOGD were appreciated and given ABJ Apul Kavam awards for excellence, prominent ones being Dr. Halka Kriplani, Dr. Jyotsna Suri, Dr. Achla Batra, Dr. Pratima Mittal, and all other members. It's a huge list you can see on your screen. Everyone was facilitated at the AOGD Abdul Kalam Award function, and a special mention for the AOGD members and Safdarjung team, which were awarded the Critical Care Champions Award very recently in the last month. Then a mention for Dr. Surbeen Gubban, who was felicitated at MEX Panchsheel for her wonderful achievements. Economic Times National Award for Best IVF Specialist in 2019, IOG Stia Paul Award for Best Review Article, and she Icon of the Year, IVF Icon of the Year for her exemplary work in IVF. Dr. Anita Rajoria won the Best Slogan Award on Friendship Day, which was in an event organized by Foxy. Regarding the forthcoming events, we have with us, I'm sorry, Bursting the Myths and Reality in RPL under the aegis of Infertility Committee on 8th September. Then we have Fetal Anomalies Workshop meeting the expectations by Fetal Medicine Committee on 10th of September. CME on contraception by Gangaram Hospital under aegis of AOGD on 10th and 11th September. Webinar on contraception by Society of Meaningful Life Management under aegis of AOGD on 14th September. Then we have Birthing Experience by Safe Motherhood Committee program on 16th September, a webinar by Quality Improvement Subcommittee on 17th September, AOGD webinar on PPH prevention on 18th September, Postpartum Complications program by AOGD and Multidisciplinary Committee with Southwest, with DGF Southwest 20th September, and an activity by Endoscopy Subcommittee on 23rd September. And we all will be meeting next for the next report of our events and celebrating this. And the next AOGD monthly meeting, as Madam said, within this month only at Deen Dayal Hospital on 24th September 21. Thank you all.
Yeah, thank you, Monica. And just yesterday evening, I forgot to add in that the Gangaram have sent a notification that they will be doing their contraception Gurukul on 21st and 22nd of September. And now we hand over to Colonel Tangri for the conduct of the monthly meeting for this month.
Thank you, Madam. Good evening, ladies and gentlemen. I, Colonel Manoj Tangri from Department of Obs and Gynae, Army Hospital Research and Referral, Delhi, on behalf of our hospital, welcome you all to monthly clinical meeting under aegis of AOGD for the month of August 2021. I am sure today's clinical extravaganza and deliberation will add to our learning and experience. I request the August members to please keep their questions or comments till end of all case presentations. Now, without much ado, I invite Surgeon Commander Rishikesh Magdum to commence with first case. Rishikesh, please. Thank you.
Good afternoon, everybody. I would request if you can see the presentation, if somebody can tell.
Yes, sir.
In today's era of heart and modern ART, serodiscordancy is not considered a deterrent to childbearing. Safe parenthood is an attainable reality to serodiscordant couples. So I'll be presenting such a case which we had with our ART center here. Before starting the case, I would like to define what serodiscordancy means. Serodiscordancy means when one partner is HIV negative and the other partner is HIV positive. It is sometimes also called mixed status. Our couple was in their early 30s, female around 31 and male around 35 years old. They presented to us as a case of primarily infertility. They were married for 4 years and cohabited together for 2 years. The cycles of the lady were prolonged for around 45 days. There was nothing significant on clinical history. They were trying for conception since last 1 to 1.5 years, and they were not using any form of contraception, nor they had taken any infertility treatment from outside. On evaluation of the female partner, her BMI was on the higher side of at around 25.8. Rest of her examination was within normal limits. On her blood evaluation, her AMH was on the higher side of 6.9, suggesting PCO. Ultrasound also confirmed that she had PCO kind of picture bilaterally, and hysterosalpingography, bilateral spill was present. On male factor evaluation, general physical evaluation was within normal limits. However, on semen evaluation, his count was on the lower side, around 12 million with 30% motility. But when he was evaluated for his infective screen, he was found to be HIV positive. He was further evaluated and his viral load was around 450 copies per ml and CD4 count was around 300 cells per ml. So we had now we had a serodiscordant couple with primary infertility. Husband was seropositive with a high viral load with oligospermia, and wife was seronegative with PCOS, wanting to have their own biological child. So the dilemmas in the management were safety of the lady against seroconversion in the process of conception, since they wanted their own biological child, and prevention of and vertical transmission to the offspring. So the options available with us were donor insemination with IU and IVF, which is the safest, but however the couple were not willing. So the other options were to put the husband on heart, and after complete viral suppression, the options available were spontaneous conception, IUI with sperm washing, standard IVF, ET, and ICSI. However, he had his sperm count was in the oligospermic range, so we were left with IVF only for this couple. So the couple was counseled and they opted for IVF ET after heart. So the recent evidence on heart says that for suppression of viral load, it requires around 1 to 6 months. And once viral suppression is achieved and maintained for around 6 months, the transmission to the couple is as good as nil. So the husband was put on triple drug regime, and he was retested after 6 months. His CD4 count were still 400 cells per ml, and viral load was around 100 copies. So heart was continued for another 6 months, and his viral load was undetectable later on. So the lady was reassessed on day 2 of a cycle for IVX-60 cycle. Since she was PCO, antagonist protocol with agonist trigger was given, and 16 oocytes were retrieved. The sperm preparation was done with colloidal silica double density gradient method, followed by swimmer. And ICSI was done in view of oligospermia as well as to reduce the risk of HIV transmission. The embryos were cultured to day 5 and 9 blasts were found. All the blasts were frozen. A special type of freezing device called the cryobiosystem was used, wherein the device could be sealed at both the ends so that there is negligible risk of transmission, and this device was stored in a separate container. On the day 2 of next cycle, the lady was reassessed and put on Proguanova, and once the ET reached around 8 to 8.5 mm, she was started on progestin for LPS. Under tenofovir pre-exposure prophylaxis, 2 embryos of grade 5 were transferred, and her serum beta HCG on day 14 was around 6,000. On day 16, ultrasound was done to confirm a single intrauterine pregnancy. Generally, the antenatal period was uneventful. She was checked every trimester for HIV and she tested negative. She went into spontaneous labor at 38 plus 2 weeks period of gestation, and she delivered a male baby of 2.8 kgs. Postpartum, mother and baby were assessed for HIV after 3 months, and both tested negative. Husband is still on heart. Now, I would request Colonel Prashant to continue ahead with the discussion.
Good afternoon, everyone. As we all know, HIV can infect people of all ages. The largest group affected, around 86%, consists of persons of reproductive age group, that is 15 to 44 years. And globally, it has been seen that 20 to 50% of people with HIV desire children. HIV, whether in male or female, impairs the fertility aspect in both the partners. In men, there is a negative correlation between the CD4 count and the motility, the sperm count, and morphology. If the count is less than 450 cells per millimeter cube, all the parameters are found to be deranged. However, the negative correlation is not found with the viral load and any of the similar parameters. Efavirenz in specifically has been seen to reduce the motility of sperms. In females, cycle irregularity, reduced ovarian reserve, tubal factor infertility has been seen associated with HIV positive status. And there is a direct effect of heart on oocyte quality because of the mitochondrial toxicity. Now, apart from the routine eligibility of couples for ART treatment, which all patients should be considered for ART, specifically in male aspect, patient with chronically detectable viral loads should be encouraged to seek fertility treatment by ART, and male viral loads of less than 200 copies per ml for preceding 6 months period are generally considered acceptable for ART. There are various measures to minimize the risk of transmission. First of all is treatment of male partner with antiretroviral drugs, which is the domain of infectious disease specialist, which reduces the serum and semen viral loads. Pre-exposure prophylaxis of the uninfected partner. In our patient, the female partner, which is started on tenofovir on the day of embryo transfer, that has been shown to minimize the risk of horizontal transmission in case of female partner, and sperm washing. Now, why, pre-exposure prophylaxis as per FDA, only 2 drugs are recommended as of date, that is tenofovir 300 mg and amtricitabine, that is 200 mg. The need for sperm washing comes from the fact that HIV shedding into the semen plasma has been seen in up to 5.3% of the HIV infected men, even when they are on effective antiretroviral therapy, and even in men with fully suppressed plasma viral loads, viral shedding in semen is possible. Hence, semen washing should be done. The principle behind that is that HIV is mainly present in seminal fluid, and as cell-associated virus in leukocyte and non-spermatozoa cell, but is not capable of attaching itself to the spermatozoa. So the recommended technique is discontinuous density gradient, centrifugation followed by 2 semen washing steps and followed by swim up. There are other recent methods also which have been mentioned in various studies like triple gradient sperm selection and continuous density gradient with swim up. In our case, we used double discontinuous density gradient. When assisted ARTs techniques are used, both with semen washing and intrauterine insemination and IVF followed by ICSI, they have been shown to drastically reduce the risk of both horizontal as well as vertical transmission. IVF along with ICSI data are very, very promising. ICSI, in case of if the female partner is infected, that has been shown to reduce the chances of transmission, because that reduces obviates granulosa cell and cumulus cell, which can harbor HIV cells. And a 10-year retrospective review has shown that there has been no incidence of horizontal or the vertical transmission. The reproductive outcomes in couples, heterodiscordant couple vis-a-vis in normal couples, data are limited and conflicting. There is a study which has shown that there has been no difference in embryo transfer, cleavage, implantation rate or pregnancy rate per cycle, miscarriage rate or live birth rates. On other hand, there has been studies which have shown that low rates of clinical pregnancy per transfer, implantation, as well as live births in seropositive women. So data are inconclusive in this aspect. Embryo storage, as has been pointed out by my colleague, we also use the same protocols which has been recommended by ASRM practice committee: storage in a dedicated storage tank, use of double bagging or sealing techniques, and storage of samples in liquid nitrogen vapor instead of liquid nitrogen itself. So the management of serodiscordant couple is multidisciplinary. Reproductive counseling is of prime importance. Offer the same spectrum fertility treatment to HIV as to HIV non-infected individuals, and which must follow universal precautions in all ART procedures. Apart from that, we must remember that couple must still be counseled about the potential risk of transmission to an uninfected partner and their offspring. It is not possible to guarantee that a female partner will not be infected when using sperm from HIV positive men. And options such as donor sperm, adoption, or not having children at all is also part of complete counseling. Thank you. And now I request Major Pranjali to come and present her case.
I shall be deliberating upon a case of chronic uterine inversion that was managed at our hospital. Our case, a 39-year-old multipara lady, presented to us with chief complaints of excessive bleeding per vaginum, along with recurrent episodes of urine retention and feeling of a mass extruding per vaginum for past 2 months duration. She had a normal delivery on 12th of November 2020, and her complaints started in the immediate postpartum period, where she gave history of having had primary postpartum hemorrhage, which was managed with uterotonics. On her first postnatal day in the hospital, she had acute retention of urine associated with dysuria, for which she was managed with Foley's catheterization for 48 hours, and thereafter she was discharged to home after assessment with an ultrasound on second postnatal day that showed a large subserosal fundal fibroid, along with some echogenic contents in the endometrial cavity, suggestive of retained products of conception. Her symptoms recurred in the subsequent postnatal period, where she had multiple episodes of urine retention and per vaginal bleeding. Also, on approximately 11th postnatal day, she perceived a pervaginal mass which was extruding from the introitus and was reposible, and repositing of the mass manually by her aided in voiding the bladder. She reported with these symptoms to the hospital, where she was evaluated and incidentally detected COVID positive. She was given conservative management and Foley's catheterization was done. In view of her COVID positive status, she was put on domiciliary care with catheter in situ for 4 weeks and was subsequently removed. However, her symptoms kept on recurring and she finally reported to our hospital with 2 months postpartum with the chief complaints. We evaluated her by eliciting a detailed history of the index pregnancy, which was by and large uneventful, and she was, other than an antenatal anomaly scan showing a large subserosal fundal fibroid, and she was induced at 38 weeks for GDM and intrahepatic cholestasis of pregnancy, and had a normal delivery of a male baby on 12th of November 2020. She gave no history suggestive of application of fundal pressure instrumentation, prolongation of second or third stage of labor, and there was no history suggestive of retained placenta. She had her last menstrual period on 16th of February, and she has delivered 3 children normally till now and has had 1 spontaneous abortion. Her father is diabetic, and there's nothing remarkable in her past personal treatment or social history. On examination at our hospital, she was well built, pale with tachycardia, with other vital signs well preserved. The abdomen was soft and non-tender. On deep palpation, a 20-week sized non-tender abdominopelvic mobile mass was felt. On per-speculum bimanual pervaginal examination, a 5.6 soft congested edematous mass was felt coming from the cervical os in the vaginal canal, and separate cervical os could not be appreciated, and cervix was seen thinning around the mass. The uterine fundus could not be palpated, and an irregular uterine contour was felt. We did an ultrasound for her that showed an enlarged uterus along with a large subserosal fundal fibroid, along with endometrial thickness of 50 millimeters with heterogeneity and vascularity, suggestive of retained products of conception. We had our differentials in the form of a degenerated large uterine fibroid or an endometrial polyp, chronic uterine inversion, retained placenta, or a succinturate lobe. Endometritis with a submucosal fibroid was also a possibility. In view of this, we got an MRI scan done for her, which revealed a 9 into 10 into 10 centimeters heterogeneous lesion in the vaginal and cervical canal, distending both these cavities, raising the possibility of an inverted uterus along with a pedunculated fibroid. On further investigation, her hemoglobin was 7 grams, so she was resuscitated with 4 points of packed red blood cells, and her post-transfusion HB was 8.4. So following which we took her up for laparoscopy with a provisional diagnosis of chronic inversion of uterus secondary to a large fundal fibroid. Under anesthesia, positioning the patient in Lloyd-Davis position and following all standard precautions, laparoscopic port entry was made into the abdominal cavity. Intraoperatively, a dimple-like depression was noted at the fundus, and a large pedunculated fibroid was seen attached near the left cornu. Also, bilateral round ligaments and fallopian tubes were seen going into the dimple, and fundal fibroid was detached using energy sources, and a Holtein's incision was given on the posterior uterine wall. Attempts to reduce the uterine inversion laparoscopically with vaginal manipulation was not successful, as the tissues were extremely fragile, edematous, and were not yielding even after incising the myometrial constriction ring. Also, as the vaginal end was bleeding profusely throughout and eversion of fundus back could not be achieved, the procedure was converted to laparotomy by opening the abdomen in layers by a midline vertical incision. Intraoperatively, a friable, foul-smelling fundal mass was appreciated and copious bleeding from the vaginal end was ongoing. Hence, we did total hysterectomy with bilateral salpingectomy and sent the specimens for histopathological examination. Post-operative recovery was uneventful, and she was discharged on 6th post-operative day. She was reviewed after 2 weeks for suture removal with histopathological report, which suggested large leiomyoma with chronic cervicitis. Over to Colonel Vinod for discussion of the case, please.
In this case, the diagnostic dilemma was there because her symptoms were thought because of the large fibroid uterus. Uterine inversion is a classic hemorrhagic disaster in obstetrics. It is defined as the descent of the uterine fundus to or through the cervix, where the uterus is turned inside out. It's an extremely rare and life-threatening condition, with the incidence in 1 in 3,500 to 1 in 20,000. When it occurs within 24 hours of delivery, we call it as acute, and when it occurs beyond 4 weeks of delivery, it is chronic. our case was a chronic uterine inversion. We classify uterine inversion into 4 types. In first degree, the fundus lies within the endometrial cavity. In the second degree, the fundus protrudes through the cervical os. In the third degree, the fundus protrudes beyond the introitus. And in the fourth degree, the uterus and vagina are inverted. Various risk factors have been suggested for the acute uterine inversion, like fundal placental implantation, cord traction before the separation of placenta, or traction of cord on a relaxed uterus, abnormally adherent placenta, a short umbilical cord, manual removal of the placenta, or connective tissue disorders like Marfan syndrome. Risk factors suggested in chronic uterine inversion are uterine fibroid, endometrial polyp, and uterine neoplasm. When the patient presents in acute setting, patient presents with severe abdominal pain, neurogenic shock, and hemorrhagic shock. The neurogenic shock outweighs the symptoms due to the stretching of pelvic parasympathetic nerves. In a chronic setting, the patient presents with chronic vaginal discharge, irregular vaginal bleeding, urinary disturbances, and mass per vagina. A high degree of suspicion is required when patient presents with irregular bleeding, and an early recognition should be there by careful examination. Our aim in such cases should be to treat the hypovolemia, to prevent any cardiovascular collapse, and reverse the coagulopathy if present. So the necessary steps: immediate assistance should be summoned, blood should be arranged, uterotonics to be stopped, large bore IV cannula system should be there, rapid crystalloid infusion to be there, and blood transfusion as per requirement. Initially, manual replacement to be tried, and generally the attempts are successful if the inversion is recent and complete, or the uterus is relaxed. If the placenta is attached, then reposition has to be tried with the placenta in situ. We have to push the fundus with the palms of hand and fingers in the long axis of the vagina. Hydrostatic method with O'Sullivan's technique with 2 to 5 liters of fluid to be infused has also been suggested to correct the uterine inversion. If the initial manual reposition is unsuccessful, use of IV tocolytics and halogenated initial agents like isoflurane has to be used. Once the uterus is reposed, then attempt should be done to remove the placenta. When uterus is restored to its normal configuration, we have to stop the tocolysis and start uterotonics. We have to maintain the anatomical position by bimanual compression till the time uterus is well contracted. This is a flowchart just to summarize the management. Once the conservative managements are not successful, or if there is a chronic myometrial constriction ring, or if the patient is unstable, we have to intervene surgically. Huntington procedure has been suggested as the initial surgical intervention with application of atraumatic clamps to the round ligament and pulling it upwards. If the round ligaments are not seen, then we can apply deep traction sutures. When we suspect the chronic myometrial constriction ring, then we can use Holstein incision, which is given preferably on the posterior myometrium. And once the uterus is reposed, we can close it subsequently. Vaginal methods have also been suggested in the correction of uterine inversion, but they are generally not preferred. One such approach is Kushner's vaginal procedure, where we enter the pouch of Douglas vaginally, split the posterior aspect of the uterus and cervix to repose the uterus. Spinally vaginal operation is also tried, and incision is made on the anterior aspect of the cervix to repose the uterus. Now, once the uterus is reposed, then we have to hold the uterus in anatomical position, and we have to give uterotonic drug to maintain the tone, and antibiotic prophylaxis to be used subsequently. Reinversion, if it occurs, then the same management protocol to be used as used for the initial inversion. Some has even suggested Matsubara-Yano compression sutures, which includes the 2 vertical and 2 perpendicular sutures involving the fundus to maintain the position of the uterus. In such cases, our take-home message is early recognition and timely management is very important to save the life in such cases. Thank you. Now I call Major Ashisha to present her next case.
Today, I'm going to be presenting a series of cases on how interventions done in early prenatal periods helps us in arriving timely diagnosis and improving the outcome of the pregnancy. My first case was a 29-year-old gravida 2 para 1 living 1 Rh positive blood group with a non-consanguineous marriage, a singleton pregnancy, referred to us at 31 weeks with ultrasound findings suggestive of non-immune hydrops. Her previous history was of a normal delivery at term, female, 2.7 kg. The child was absolutely healthy. In her present pregnancy, her first trimester scan, no increased NT was seen. First trimester combined screening was of low risk. No anomaly was detected on a scan done at 18 weeks. However, an ultrasound done at 30 weeks was suggestive of non-immune hydrops. During the evaluation at our center, ultrasound finding confirmed polyhydramnios, placentomegaly, pleural effusion with diffuse subcutaneous edema. Dopplers done showed middle cerebral artery peak systolic velocity was 76 centimeter, suggestive of fetal anemia. First investigation we got done was fetal echo to rule out any underlying cardiac anomaly, which came out to be normal. Then we went ahead with chordosynthesis and sent the sample for a panel of tests. The fetal hemoglobin came out to be 11.2. We sent the sample for the infective screen where toxoplasma, cytomegalo, and parvovirus infection came out to be negative. Rh minor antigen blood groups like KEL, Duffy, C and S were not detected. QF-PCR for common aneuploidies was normal, and the sample was sent for chromosomal microarray, DNA storage, and whole exome sequencing. The report of whole exome sequencing helped us in clinching our diagnosis of BARTH syndrome. It is an X-linked recessive disorder with a mutation in TAZ gene. It basically causes growth retardation and lot of learning disabilities in children with in utero presentation as hydrops. It was a breech presentation pregnancy and the couple was well counseled in the antenatal period. She had an IUD at 36 weeks but opted for a vaginal delivery. Coming to my next case, she was a 29-year-old gravida 2 para 1 living 1 with a third-degree consanguineous marriage found to have post-axial polydactyly along with bilateral hyperechogenic kidneys at a scan done at 20 weeks. Her first trimester scan as well as screening was normal. On eliciting her detailed family history, she told her first child, who is now 4 years old, was also antenatally detected to have polydactyly with bilateral echogenic kidneys. She was reviewed that time by fetal-maternal specialist and geneticist and was advised chordosynthesis to rule out any underlying genetic disorders along with USG KUB for both the parents. However, they were lost to follow-up and no genetic evaluation could be carried out for this child. Now, with the possibilities of both the offsprings being affected with ciliopathies, in joint consideration with clinical geneticists, we decided to go ahead with amniocentesis and send the sample simultaneously for fetus and elder affected sibling. The result was a Bardet-Biedl syndrome, which is an autosomal recessive disorder. The syndrome has an incidence of 1 in 1 lakh to 2,50,000 and basically presents with learning disorders along with progressive visual impairment. The couple was counseled adequately this time also. However, they decided to went ahead with the pregnancy. The problem in this syndrome is as the child grows, that is the time all these manifestations progress. My last case is a 30-year-old gravida 2 para 1 living 1 non-consanguineous marriage, a singleton pregnancy, which was detected to have severe lateral ventriculomegaly at a scan done at 29 weeks. On eliciting her history, she told postnatally her first child was detected to have aqueductal stenosis and VP shunt was put at 6 months. No genetic evaluation was carried for this child. Now, in view that both offsprings, that two male phenotypes being affected, the most common etiology was most likely genetic. Thus, directly amniocentesis was done to find out the genetic cause for the evaluation of the index child and the carrier testing of the mother. We found our result to be an X-linked hydrocephalus with stenosis of aqueduct of Sylvius, which is an X-linked recessive disorder. Thus, are both male phenotypes being affected, and the underlying mutation is in L1 CAM gene. It has an incidence of around 1 in 30,000. However, 5% of female carriers also may have mild symptoms. Thus, in all our cases, a timely intervention done helped us in evaluating her first pregnancy. Also, prognostication of the next pregnancy was done.
Now I would request Colonel Rima ma'am to come for the discussion of the case.
We all understand that the Human Genome Project has caused a revolution by looking at more than 20,000 genes. And this explosion has majorly impacted our fetus, because we can now bring about a paradigm change in the prognosis of the fetus by prognosticating them on time. Now, what are the tests available in the armamentarium? There are many, but what can be offered and what are recommended? It all goes on the clinical phenotype and in consultation with the clinical geneticist. We have the rapid tests that have been there in our armamentarium for a long time. They're looking at 5 common chromosomes, the QF-PCR and the FISH. Conventional karyotype has stood the test of time. It's the gold standard for looking at the 46 chromosomes. It's mainly used when we are suspecting trisomies or major problems in the chromosomes. But what has helped us take a major leap forward is the microarray. And why? Because this is not subject to errors since it's not manually done. It gives us 6% additional diagnostic yield as far as pathogenic copy number variations are concerned as compared to the karyotype. And therefore, when we looked at our own data, we found that out of 217 microarrays that we sent, 12.9% showed some problem, and out of which 6% could have been picked up by karyotype, but it was the other 6 that could have been missed. And therefore, microarray in the current era is the way forward when we evaluate fetuses with structural abnormalities. Even ACOG recommends that whenever we have a fetus with structural abnormalities, chromosomal microarray is the way forward. But as you saw in our 3 cases, we looked at the genes. So we moved way ahead from the chromosomes to the genome. When we talk of genomics, the new sequencing methods are capable of rapidly analyzing the genome at increasing resolution, which have transformed the diagnosis of single gene and oligogenetic disorders. The targeted testing consists of disease-focused multi-panel tests, which look at the phenotype and tell us that there's a problem with this child. And this extrapolates to prenatal testing, like in our 2 cases of Bardet-Biedl syndrome and X-linked hydrocephalus, where the family history gave us a clue. They were subjected to clinical exome sequencing, and that made us arrive at a diagnosis to offer prenatal tests. We also have the whole exome sequencing in our armamentarium. This looks at all the coding regions, which constitute only 1.5% of the entire genome, but are responsible for 85 to 95% of the problems as far as genes are concerned. A patient of BARTH syndrome for non-immune hydrops underwent a whole exome sequencing, and we could clinch the diagnosis. Whole genome sequencing is there in the armamentarium, but it's rarely used. So my friends, when we looked at our data at AHRR, we saw that with time, the number of genetic tests have been increasing in addition to the aneuploidy screening that we are doing. Sanger sequencing, which is the gold standard for confirming the diagnosis when it's been established in the proband or the index case, or when the whole exome gives us a diagnosis, it needs to be confirmed by Sanger sequencing. That is definitely catching up with karyotyping. And monogenic disorders are forming quite a major chunk of the disorders in our setup. So what we want to emphasize is that family history and pedigree charting is an invaluable tool. It's very important, but the tests cannot be ordered at random. They need the opinion of a clinical geneticist to actually come to a diagnosis and to order the respective tests. So here I would request our clinical geneticist, Lieutenant Colonel Aradhana, who's the only geneticist in the armed forces, to give you the take-home message today.
So to sum up, I would like to, thank you, ma'am. To sum up, I would like to say to the audience that the field of genetics is rapidly advancing, Now we have battery of genetic tests, as has been said by Rima ma'am. But now, and this is available at affordable prices compared to what it was 5 years back. So, but then how to make the choices? Still, despite the availability of these tests, as pointed out, family history and pedigree charting remains invaluable tool because it's going to guide us towards a possible mode of inheritance. Secondly, one other thing which I would like to emphasize upon is the evaluation of proband. It's very pertinent to get the diagnosis in proband because we have seen in few cases which were labeled as a cerebral palsy, one after the other, the children were affected and ultimately they were found to have a genetic basis. So in this era, when we have got so many tests in the armamentarium, we should have an eye with the involvement of multidisciplinary team, including your geneticists and neurologists and other subspecialties as and when required. And when we have a correct diagnosis, that helps us further in accurate genetic counseling, providing the risk, assessing the risk of recurrence, and providing the prenatal diagnosis, thus further improving and giving the closure to the family. Thank you so much.
Thank you. Thank you, ma'am, and thank you for this. If there are any questions, we would be happy to take them.
Thank you very much, organizer Dr. Nathangri. This was a very good presentation. Very good presentation. Congratulations for that. So now I think I would like, there are no questions in the chat box. I would like to invite judges for today's session. Dr. Sudha Sarjan, Dr. Shashilata Kabra, and Dr. Aparna Sharma. Dr. Shashilata Kabra has already joined in. Now she can ask questions.
Yeah, it was first I must congratulate. It was a brilliant presentation. All the cases were very good. And my first question is to the case discussed on chronic uterine inversion. What type of inversions, complete or incomplete, becomes chronic and why?
Ma'am, generally the complete and the total, in the more the prolapse, the more the chances of getting it in the constriction ring to be formed. So generally total, prolapsed and the inverted, they generally go into the constriction, chronic uterine inversion.
Okay. Anybody else would like to comment on this? Complete or incomplete, which becomes more chronic?
Okay. So any other question, Dr. Shashilata, you want to ask for the other cases? Do you want to ask any other question for other two presentations?
Good evening, everyone. Ma'am, can I?
Yes. Please, Dr. Aparna, please ask questions. Yes.
Yeah. So I would really like to congratulate the whole team for presenting such wonderful cases. So I have a I'm just curious to know from Dr. Rima, very nicely presented work, Dr. Rima. I would like to know, like you said that you did 270 microarrays, of which 12.6% came positive and which was over and above the karyotype. So
no, they were, so we had, this was not over and above. We looked at the whole data and we looked at the deletions, duplication that could be picked up by karyotype. So if we were ordering a microarray, because of the cost factor, we were not ordering for a karyotype. So this was looking at the data per se with Aradhana, who's the geneticist. She evaluates all the reports on her own. And so so we came to a conclusion that 6% of these could have been picked up by karyotype, but the others could have been missed. So it's not together. It's isolated microarray.
Yeah. So the other thing, the 2 points that I would like, so I would have loved to know the distribution of the indications.
Yeah, I know. It was too short a time to get to it.
Yes.
Yeah.
And the other thing is that how many were, VOUS or VUS, if you call it?
Yes. So we have not mixed there were a few cases. There were, I think, 3 cases out of those 28 that were variations of unknown significance, but the structural abnormalities that were there on the ultrasound, we have kept it as a record to probably, if required, because these microarrays, you cannot tell that it's of unknown significance unless something else comes up later, because there's a lot of study that's still happening at this end. So we've kept that data with us, depending on the next pregnancy, how it goes. We may not offer a prenatal, but if there are additional ultrasound findings in the next pregnancy, we may utilize those tests again.
So if I may intervene, ma'am, as per the current recommendations for the prenatal genomics, we are not providing VOUS. We are only providing a likely pathogenic and pathogenic. So VOS would on demand, suppose if I ask, then the lab may give me, because that's why my own knowledge or my own understanding. But we cannot take decision based on the VOS as far the prenatal goes. So we have to be very firm. So we are not getting VOS reports in the prenatal genomics.
Okay, thank you.
May I now request Dr. Sudha Salan, ma'am? Please ask questions, whatever you want to ask, from the presenters.
Can you hear me?
Yes, ma'am.
Sudha ma'am, requesting you to please log out from one device.
Ma'am, please unmute. Yes, yes.
I have unmuted. So I want very good presentations. I want to talk about HIV patient. What was the outcome of the baby? Was the baby HIV positive or not? Hello? 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 Am I audible?
Ma'am, am I audible to you?
Yes.
Yes, you both are audible.
Yes, ma'am. After that, as my colleague Sajan Kumar Rishikesh has mentioned in the end of his presentation, that after 3 months, both the mother and child were evaluated for HIV, so there was no evidence of horizontal or the vertical transmission.
So the father is continuing HRT.
Yes, ma'am. He is continuing.
Heart treatment.
Yes, ma'am.
Okay. Okay. Yeah, very good.
Thank you, ma'am. Thank you.
Thank you very much. Thank you very much, and thank you for just doing everything on time. So now I would like to invite Dr.
Yeah, before we go on to our quiz, while we were presenting our secretary's report, I think a few slides got skipped. So I'll request Monica to please, complete the report.
Yeah, so we had a few events under AOGD Infertility Committee as well. First one was IVF pregnancies. How are they different in association with NARCHI on 3rd August? Male infertility, the most ignored in association with Haryana SR Association on 12th August. And there was a webinar in association with DGF North on 18th August. I apologize for just skipping over the slide while presenting.
Yeah. So I think over to Rekha for the quiz. Rekha?
Good afternoon, everyone, and thank you, Dr. Achla. So now we are going to start our very interesting session of AOGD monthly meeting quiz. And so can Shivam, have you posted the link in the chat